Kate. I'm the program manager for the Patient-Centered Primary Care Institute, and I'm here to welcome you and get our webinar started this morning. Before I turn things over to our presenters, I wanted to review a couple of things about the technology we're using. So there are 80-something folks registered for the webinar today, so everybody is on a global mute. Everyone is on mute and will remain on mute throughout the presentation. That being said, we do have plenty of time set aside to take your questions or to talk about examples you have or that you've come up with or things you've seen. So please feel free to use the questions pane in the GoToWebinar control panel to write in and share those observations or questions with us. One question I can anticipate is whether or not the materials from this webinar will be available, and they will, the slides, and an additional tool given to us by the presenters are available on the Institute website, and a recording will be posted later on today. So you can look for that and send that to any team members who may not have been able to join us this morning. This webinar is hosted by the Patient-Centered Primary Care Institute, which is a partnership launched in 2012 with the Oregon Health Authority to help get technical assistance to practices working on the Patient-Centered Primary Care Home, or PCPCH, model of care. Likely, a lot of you are familiar with some of the Institute resources, and that's awesome. Maybe share them with a colleague today who may not be as familiar, but there are a variety of things available to anyone at any time on our website. Things like online learning modules that go over the foundational concepts of the primary care home, as well as the 33 PCPCH program standards. There are a library of recorded webinars. We began doing them in January of 2013 and have done them consistently since, so you can view all the recordings on the website. You can also look at resources like checklists or sample policies, toolkits, or guides by a category or PCPCH standard. And you can also join our email list so you can learn about in-person training opportunities when they're available, things like learning collaboratives and others. As I mentioned, the Institute is really set up around technical assistance around the primary care home model, or PCPCH model of care. That is Oregon's way of defining and recognizing medical homes. You can learn more about the PCPCH program and read about the standards at their website, which is primarycarehome.oregon.gov. All right, I am super pleased to introduce our presenters today. We have Casey from Care Oregon. Casey brings a background in clinical nursing and process improvement to primary care medical home development. She's a lead trainer for Care Oregon's PC3 collaboratives and provides practice support. She leads medical home initiatives. She has led medical home initiatives within Multnomah County Health Department and has been a training facilitator for the Institute and building blocks of patient-centered primary care trainings. We're super pleased to have her share all of her knowledge today. And then we also have Maribel Lopez, who's been a medical assistant at Virginia Garcia for over 10 years, during which time Virginia Garcia was a leader in implementing medical home and team-based care. Her team works with some of the most complex patients in the clinic, and the provider she works with recently expressed how much she relies on her superior scrubbing skills. So we're super excited to have both of them with us today. Were the folks from Virginia Garcia able to get on? Could you just say hello to me real quick? I know you were having trouble connecting. Yeah, we can hear you. All right. Great. I'm so glad you guys were able to get on. So I think I'm going to turn things over to Casey and have her get us started.
Great. Thank you so much, Kate. Good morning to everybody out there. I'm really thrilled to have all of you on the phone today. And I think I noticed when I was looking through the folks who joined that we have a lot of both operational folks and also some clinical leadership in the group, which is fantastic. I'll be trying to direct this toward both of you as a team, and I'm looking forward to you all thinking about how this work moving forward can really benefit your clinic. So what we're going to look at today are three big things around scrubbing and huddling. One of the main things we're going to talk about is kind of a scrub and huddle 101, and really just look at the core basics of what it is to scrub and what it is to huddle. Some of you may be familiar with this. For others of you, this may be a first time in even thinking about these terms. The second thing we're going to talk about is ideas and ways to think of integrating and scrubbing and huddling into your current work. I firmly believe that it's one thing for me to just kind of talk about what scrubbing and huddling are. Of course, it's a completely different thing to go back to your clinic and try to actually get it going. So as a process improvement person, I really do feel that we should spend a little bit of time with some ideas around how you could begin to launch this process at your clinic as well. And then the third thing that we're going to just touch on briefly is really how scrubbing and huddling relate to the PC/PCH standards. Just going to kind of direct you to the places you can go to get more information. And I should have had the fourth thing on really is Maribel. Maribel, coming from Virginia Garcia at the end, is going to have a chance to talk to you about what the experience of scrubbing and huddling has been like for her at Virginia Garcia. And she'll be able to tell us some of the challenges that she's encountered, some of the reasons it's working, and they've continued to do it after all these years. So of course, that's the most fun part of it. So I'm really looking forward to getting to Maribel and being able to share her story with us. So why team-based care? I think we have to go back to that every time we talk about a new core process of the medical home, and really it's just a reminder to us of why we're spending all this time working so hard to implement some of these new processes when we also know we need to care for patients, and it takes a lot of work in both ways. So if we remind ourselves that increasingly primary care is being asked to just be responsible for quite a lot of things that are represented on this slide. We always see patient satisfaction as kind of the roof over it all, or kind of the cover, but a lot of the state standards that through PC/PCH, we see it in the CCO metrics that people are trying to achieve around the state. In some cases, it's coming up in emerging payment models that might affect primary care. And so there are a lot of bullet points here, right? We have a lot of process measures that we feel increasingly accountable for with our patients. A lot of clinical outcomes as well. We want it, and so not just chronic diseases anymore, but we're also potentially trying to decrease utilization at the hospitals and the EDs as well. This is a lot of work for primary care. I know it creates a lot of anxiety for people, and so how are we going to do that? Well, team-based care. Keep going on that one. So the other piece that we also know is that as we dive deeper into how much time it would take to go back to that house that we looked at and address all those things, well, many people are familiar with this particular bit of research that decided that it would, estimate take for a panel of around 1,200 people, it would take upwards of 18 hours a day just to provide the preventive care measures that were needed for all of the patients on that panel for a PCP. That's an impossible task. And so to live in this new world and to provide the care we know our patients need, we need to increasingly be thinking about how we can leverage everyone on the team. The provider can't do it all, and scrubbing and huddling is really a key way that we can leverage the skills that other team members do have. I like this slide because it reminds us as well that in primary care there are many strategies that we can use, kind of break things out into pieces in order to address all of our patient needs. And when we look to the far left, we see that panel management is the core process that underlies everything. We are unable to move on to care management or complex case management if we haven't built a really strong foundation around panel management. And I'm sure in other webinars or in other settings, you've talked or learned about registries and outreach for gaps in care. Planned visits and thinking about how we organize those visits to truly address the needs that our patients have, how we think about that in advance, and then how we deal with it when the patient is actually in front of us, is the day-to-day work that helps us organize what we do so that the patient needs are, in a more timely, efficient manner, being handled. And in primary care, this is really the place that we need to begin. And we do that by leveraging really our teamlet of our provider and MA. So we're going to talk about that. I think I moved forward one slide. There we go. All right, so what is planned visit? It means that no matter the reason the patient schedules their visit, when they walk in the door, the team knows which evidence-based care the patient would ideally receive. Now, does that mean that every single situation the patient's going to get all of the care that they need? No, absolutely not. But it does mean that we're making our best effort to identify in advance what are some of the gaps that the patient might have, and if we have the opportunity, can we try to close them? So essentially, that's what scrubbing is. It is looking closely in the chart to find those gaps in care. And then huddling is the piece where we communicate around how we're going to close those gaps. So when I talked about, traditional methods of how we manage workflow, in the past, so much of the work we know came through the provider, and the provider was responsible for monitoring if everything got done. Did all their medications get refilled? What happened with test results? Are they getting the preventive care that they need? And if all of that has to go through the provider, that looks like, kind of the hourglass shape. It's going to get bogged down right at the provider. And the provider would then be responsible for determining who else is going to do that work. It goes back to that 18 hours in a day needed. And we really, know that that's not realistic. But what is more realistic, I'm sorry, my keyboard's a little bit sticky here. What is realistic is thinking about how we work more in parallel. And I think this is something that primary care is poised very well to do. And particularly the MA on the team, or perhaps the LPN, as well as some of the administrative folks, can really do a lot of this work. They can help to think about what preventive measures has the patient not received, and take that work off of the provider. A lot of this work has to do with digging in the charts and looking for information. And so we can think about how we strategically plan that information in advance and allow other people on the team to take care of it. So scrubbing. It begins with identifying the key health conditions that your clinic or team wants to scrub for. In most cases, what you'd want to spend a good bit of time on is thinking about the measures that your team or your clinic is really trying to improve. This is actually a place where you might spend quite a bit of time. There are a lot of options that we'll talk about in a little bit that you could spend time addressing, hundreds. However, we realize that this is something that takes quite a bit of energy for everybody at the clinic. So what I recommend is that your leadership team in operations, or the person who is your key medical clinician, think about what are the areas that you feel most clinically responsible for addressing. So whether that's been that you're really concerned about your diabetes population, perhaps patients with hypertension, or maybe it is complex patients with mental health diagnoses that you've really struggled with. That's the area where we can begin to look and find out if we can address those patients in advance. Then we want to move down and think about who on the team could look through the charts and have look through the schedules a couple of days in advance, or even a week in advance, to identify those gaps. So this is really a great role for the office staff, for MAs, and even medical students who might be in your clinic, because as we'll talk about, that information, we'll show examples of it in just a little bit, can be very clearly delineated and written out so that it's not a medical decision-making. It, in fact, can be more of an information-gathering exercise. So what somebody so an MA, for instance, when the schedule has been set and they know who's coming in, a lot of the time the MA will look a day or two in advance as their time allows, and they'll be able to go in and see what gaps still exist and go back through the chart, take note of that, and then document what needs to be done. So the documentation piece is also going to be a place where we'll spend a lot of time. You're going to want to find a place in your EHR, such as the visit notes or the care coordination note, hopefully not a paper log anymore, a place where this will be visible to the provider and most easily accessible to think about those gaps and make decisions about what needs to be closed that day. It's very clear that there are a lot of options, obviously, in the EHR. There's also a lot of places where we can document. So we'll talk a little bit more around how we can more think as a team about where we want to document and do that in a kind of a systematized way. And then the last piece that we'll spend some time talking about is how we would huddle. So what we're going to think about then is what would be the appropriate time of the day to come together as a team and talk about those gaps. So if we this main scrubbing workflow is really the key piece to all of this. And what I wanted to just go back and review is that it's a 4-step process. We're going to look at what the key health conditions that our team wants to scrub for, organize them, and determine what our highest priorities are. Then we're going to think about who on the team might have the ability to go in and investigate a little bit and figure out what those gaps are. That person, if they have the chance then to document that information in a centralized place, it's most easily accessible to the providers to then communicate with other people on the team and plan the visit. So there are quite a lot of options for those measures. If you turn to your PCPCH standards and the 2014 criteria, when you go to Core Attribute 3, the Comprehensive Whole Person Care, and Standard 3A, there are a lot of options. That's on page 43 for choosing planned care measures. You've got the United States Preventive Task Force recommendations, A and B. You've got Bright Futures recommendations. And as I said, there's kind of just a limitless area that you could choose to address. I think a lot of the clinics have really focused on the task force recommendations and also Bright Futures because they're so comprehensive and they really give you a lot of areas to consider for both peds and in your adult population. I'm not suggesting that you work to these standards for PCPCH as a way to determine clinical care, but I think a lot of areas have found that these measures align so closely with the work that we know to be the right clinical decision to make and kind of the right thing to do for our patients. And so it does provide a great place to start. And the next piece that we'll talk about is that the person scrubbing is really going to need to know where to look for the information and what they're looking for, then where they need to document, and how they're going to go about documenting. So this piece in itself is probably one of the more time-consuming clinic development pieces. When you think about standardizing this work, one MA could find that if they go in and look for a particular provider for a diabetes A1C test, they may have found that back in a progress note. In other cases, the provider will be documented in a flow sheet, or somebody else may have entered it there. So for any given person who needs to find that information, if they have to look in several different places in the chart for it, that in itself will be incredibly time-consuming. So one of kind of the first tasks is just to think about where are we documenting information in the chart, and are we all doing it in the same place? Could we make a decision and kind of come to a compromise around what might be the most appropriate place to document that information so that somebody who's looking in the chart will have an easier time pulling it back out? At the same time, for the MA who's documenting, I know every team tends to have its own style, but this is one of those situations where standardized documentation is actually going to be far more helpful than to allow for any kind of team flexibility. And what you might find to be useful are to develop some smart phrases or other just standardized documentation tools that everybody who's doing this information will use. So in this case, this is an example of the scrubbing tool from Multnomah County Health Department. And if we look at this tool for a patient with diabetes on the problem list, so it's very clear about where the person would look and what the guidelines are, the parameters for that patient, that they'd like to see the patient have an A1C every 3 months if their A1C is greater than or equal to 8, or every 6 months if it's less than 8. So the person in this case would be an MA or an LPN who might be scrubbing in that chart is going to be looking exactly for that information and the date that would show that that had been done. They'll do the same thing for the LDL. They'll do the same thing for the dilated retinal exam. They'll be looking for that information. And then the next step, what we'll show on the next slide, is then how they document that information. This is clearly a lot of information to be looking for, and it will be in a lot of different places. Certainly, proof of dental exams and dilated retinal exams can be incredibly challenging for clinics to get that information, and this is an area where you may find at first this is a real challenge. It might be something that you would need to add on down the line, but in most cases, standardizing the labs and where that information can be found can be more straightforward and will save you a lot of time down the road. I know that traditionally this is an area where the provider has spent their time looking through the chart for this information in addition to reviewing the problem list and the past history. And so it can be really challenging for the provider to think about giving this information up to another person on the team. But in the reality, when you think about it, this information right here is pretty straightforward, and it's more kind of the yes, no, has this been done? And so this doesn't eliminate the need for the provider to, I mean, obviously to go back in and review the chart for other reasons, and we're not suggesting that, but we are saying that if you can take a piece of it out, looking for this kind of data information and extract it and put it in a more centralized location, that is a time saver. Because rather than the provider needing to look through many layers of the chart to find this information, now they're going to go and review history, review problem lists, review other progress notes, but go to one central location to find this data and to know if it's time today to suggest to the patient that we need to do this or we need to have you come back in to take care of it at another visit. So then when it comes to scrubbing, this is related to the documentation then that the person would use in the chart. So what we have here, again, this is another example from Multnomah County, is that there's a smart phrase created for well women 18 and up. And so the person who was doing the scrubbing would start by initially entering this smart phrase somewhere in the chart, wherever they decided that they needed to do it, maybe the care coordination note somewhere else, and it would automatically populate with these columns of information that also, again, offer up the guidelines so that the person scrubbing doesn't need to know all of this information themselves. It's right here in the chart. The piece that they are responsible for documenting in is the far right column. You'll see in the far column it offers the date for next due, and they default to now if not documented, but it allows for the person to change and then enter a new date. So the MA would go in and kind of tab on or F2 on down through and be able to enter the date that it had been done so they knew it wasn't due again or when it's next going to be due. And if it's due now, that would be entered in that information would then get transferred to another location in the chart. So you'll see that there's quite a bit of information here. And there could be multiple smart phrases for people with different chronic diseases as well. So this could be in a woman's chart as well as if she had diabetes, there might be another smart phrase for diabetes. There might be a different one for hypertension, and they would just all kind of line up on top of each other. You know, in our new world of changing EHR, it is also possible that your HMAs could be relied upon, and it may be that if you have certain health, sorry, I told them I should know this, the acronym, so the health maintenance alerts as well may populate for you preventive information and kind of give you that flash to say, okay, this is what's due for this patient as well. If those exist and they are working for your organization, that's absolutely another area that you can use. The reason that a lot of these smart phrases were developed was because a lot of that technology didn't quite exist in a way that the clinics felt like they could work with it on a daily basis, and it actually became more advantageous to develop a process that was personalized for the clinic and had smart phrases that, excuse me, people could go in and just manipulate themselves and control the date that they are next due. So something to think about as we're moving forward on that kind of scrubbing is that it really does take quite a bit of time at first. Some of you might have seen that one smart phrase and thought, oh my goodness, if we were to layer that on top of a few other smart phrases and ask our staff to go into charts and find all of that information, that is going to take a lot of time. And it's true. I think Mary Bell will say that in the beginning, that really does take a lot of time because it's a new process and people are unfamiliar with it and they have to think through, you know, where do I go to find this piece of lab? Where do I go to find that piece of information? Which form do I need to find, you know, to find out if they had their retinal exam? So it does take a lot of time at first. But then as it becomes more routine, it's faster. And then as the charts get updated and those dates are in the chart kind of front and center saying when something is next due or that it's not applicable to this patient or we already did it, then it's a lot faster because that information then stays front and center on maybe the front page of the chart. So at that point, it's not something that people need to turn to frequently. They can quickly go in and just go down through it. So I'll have Maribel address that. I wanted to come back to, again, that resolving the documentation and consistency and kind of say you just got to do it. I know it's a sticking place, and it really does. It's probably a place to spend a little bit of time as you talk to the providers at your clinic. But I think it's time worth spent when you're able to figure out across your providers exactly where some of these key measures need to be documented. You know, maybe not everything, but the key preventive measures that you're looking for. If everybody's documenting those in one centralized location, then you're in a much better position for this to be easy, so that an MA who might move from one team to another would know exactly where they would find it. They wouldn't have to think about it, and that for them is going to be an incredible time saver. And in fact, if you think about it, it's also a time saver for providers as well, because if that information is in the front of every chart, when they're covering for somebody, they will be able to go and find that information right away without having to themselves hunt through that chart. So, you know, kind of just do it. Spend the time that you need to spend negotiating and figuring out where we are going to document. I think in the beginning, too, the reason this does take a little bit of time to get up and running is that there will be those inconsistencies, and you do have to work through them on all of your charts. But once you've gotten through that backlog and you have a procedure in place for everybody documenting in the same place moving forward, you're in a much better spot, and it will take a lot less time. The communication with everyone on the team throughout this process is really key. There is going to feel, I kind of mentioned this before, but I think that it's something that's worth emphasizing a little bit more. One thing we found when we were first helping some clinics to start scrubbing is that providers did feel incredibly responsible for addressing all of the gaps as soon as they got noted. And it just isn't realistic to be able to do that, right? And it's funny because I had always been, you know, a lot of these providers in the past would be looking for those different preventive measures. Why this time around did people feel that they were under more pressure to respond to them? And I think it's because it was more central in the chart. When something's written down, suddenly people feel the need to have to address it. And I think that it's really important to have that conversation throughout the clinic and reinforce that just because this information is now front and center and we've pulled it out, it doesn't mean that you're being held as a provider for addressing every single gap that's there. It might take several visits to work down through it. And it's going to be important to reinforce that. And if you sense that a provider is getting kind of anxious and stressed about it, that's another place to have that conversation and remind them that we're not saying it needs to be done immediately, but it is something that would need to get, we want to be looking at it down the line and just trying to work through the backlog. Obviously, as well, patients may or may not agree to a lot of the preventive measures that we think are important to them. And that's obviously important to, you know, we're not going to be forcing them or overly encouraging them to do something that we wouldn't have done before. It's just that we're trying to take advantage of every opportunity we can to offer up that information to patients. So the third piece that I'm realizing the slide doesn't show you, and I'll go back one so you can see it. So when this particular example, you may ask the question, where is this information then going to get documented for the provider to look at? And that information, in a lot of cases, could go just straight on the schedule in the appointment notes area. What a lot of teams have done is create very shorthand terms and letters to indicate what is needed. So whatever shorthand works for your clinic, you may just put LDL initials, you know, on that patient's appointment notes. Something like that would indicate what is due at that time. If there is nothing due in the chart, a kind of a fun way that one clinic decided to do it was to put a smiley face, so kind of the keyboard smiley face, to just indicate that this chart has in fact been scrubbed. So that was a way for them to know that even if it didn't appear that there was any new information in appointment notes, the provider and the other people on the team could see, oh yes, that's been scrubbed. And that kind of consistency is actually important, not just for providers reviewing the charts, but if you think about it for the other MAs who might be covering for the scrubber. If they've come on late, they might, or to cover for somebody, they might not know if a chart has been scrubbed. Additionally, you'll get walk-ins. You'll get other people added to the schedule. So how do we know if those charts have been scrubbed? Something like the smiley face in appointment notes lets us know that somebody did already take a look at that chart and scrub it. if that wasn't there, then the person, if they had the opportunity, might be able to go in, scrub that chart as quickly before that walk-in is seen. That's obviously kind of an idealized thing. Certainly does not always happen, and I think Mary Bell will say that that's a real challenge. But when we're kind of thinking through priorities and what we really would like to address, that in itself is an option. And when we have a process in place to make that standard and obvious, it's more easy it's easier to go back and take care of it. The other thing to think about is that this is a real role change. When you have somebody who might have been providing direct provider support, and now they might be asked to go in and scrub the charts, it will seem scary at first to go in and have to be responsible for that information. They might feel that there's a lot of pressure on them. And so one thing that we've done is really spend time team building just before a process like this gets rolled out. It does feel like it's a time that's important to bring the team lead or the different folks in the clinics together to talk about what they feel like are going to be their challenges, what's going to get in their way, to spend time talking about how documentation is going to be more consistent, and to basically work down through how it is that we're trying to make this process as easy as possible. One of the biggest things that we've heard is that providers struggle in the beginning to trust that this information is going to be correct. It's not that they don't trust their MAs to do a great job. It's just that in the past, the providers themselves have been responsible for finding this information. And so all of a sudden, when you're handing part of this task off to somebody else, it feels like you're not sure it's going to get done. And so I think that it'll be important to examine, do you have trust within the team that this is going to be done well. And when that doesn't exist, it's something that you'll need to spend some time on thinking about those personalities and people that maybe could use a little extra support, and directly providing that to them. Maybe walking the provider through the work of the scrubber so that they can see that that information, it truly is ending up there. Providing a little bit of chart checking as well. And this is an area where you're going to want to provide elbow support to the scrubber. Go back in and do a little bit of chart checking to make sure that they were finding the information and understanding what they're looking for. But once you have addressed that and you can provide that competency checkoff, then you're more good to go. That's when the train gets rolling and everybody's moving much more quickly. So we'll have a chance for folks to ask questions earlier on about scrubbing. I want to move now to huddling. And huddling is really just the completion of the picture. It kind of rounds out our communication stream. If we didn't spend a little bit of time talking about the information that was identified in the scrub, ultimately we're not taking advantage of, we're not ensuring that that information is going to get acted on. So what is the huddle? A huddle is an opportunity to prepare for the day. We can use this opportunity to identify what patients are coming in for and why, to know what lab equipment might be needed for the visit, identify the preventive health needs for those patients based on information that we're now going to have in the schedule and in the appointment notes. We can make sure that all the patients that are on the schedule need a visit with the provider. So if your clinic has the ability to have other folks come in and take care of that patient need, this would be the time to talk about that and to try to move them to a different schedule. So for instance, if it is an immunization and you have an ME clinic or somebody at your clinic who could just take care of that, you might be able to move that from the provider schedule. Additionally, looking at those appointment notes may give you an opportunity to think about how you would do a warm handoff to behavioral health or to the RN. So if you have a patient coming in with diabetes and you have someone at the clinic who is generally responsible for health education of diabetics who might be taking that opportunity, if in advance somebody has looked at the chart and seen, oh, we have so-and-so coming in today, and I do want to make sure that they touch base briefly with the nurse and maybe talk a little bit about how things are going with their nutrition and diet. If you're able to see that, if you take the time in the morning to notice that, a lot of the times you can pull a nurse or a social worker or somebody else at the clinic, a health educator aside and say, hey, so-and-so's coming in today at this time. Would you mind being available? I'm going to do a warm handoff, which means I'm going to introduce them to you briefly, and then you can set up an appointment with them later on. That warm handoff is really critical to encouraging patients to come back and see somebody else, particularly the social worker or nurse or health educator. for people who are doing complex care management or case management or working with people with complex behavioral health needs, time and time again, if all it is done is that the provider says, oh, and by the way, I'd really love for you to come back and talk to our social worker. I think you could really benefit from that. If they say that, but don't also have the opportunity to say, can I introduce you to that person really quickly? I just want it, they're part of my team. I work with them. That warm handoff itself will increase your ability for that patient to come back in immensely. They will have seen the person. They will just even build the slightest rapport. So you're basically helping other people on the team to be more successful in their jobs when you identify in advance what other needs might be out there and then take the time to let them meet. Of course, huddling, if you need to review any outside records, you might be doing that then. And then we talked a little bit about proactively identifying people who are have chronic disease or maybe are chronic no-shows. And so this would be a situation where somebody on the team is able to look in advance and maybe call them. So at some other systems, I know that some of the scrubbers scrub a week in advance. They figured out how to do that so that they can more proactively address people that they know chronically don't come in. So essentially, the huddle is really a time to talk about a lot of things. And you don't need to cover all these things, but you have a lot of options. So the basic huddle mechanics. The idea is that in general, the core people who would come to a huddle would really be the provider and the MA who work together daily. They're going to be the ones to review for the provider to say, okay, there were 5 things that we did scrub for. I think today I'm going to try to address these 2, and then we're going to see if the patient can come back. If the provider and the MA have the ability to just briefly touch base and know what's going on, the MA can more proactively support the provider in getting ready for that visit. Similarly, we talked about the communication for the warm handoff. I would say that in most cases, your behavioral health person, your RN, other members of the team are not going to join your huddle because you probably, they might be on a different schedule, they might be covering for somebody else. But if you've identified that you need to touch base with them at the huddle, then you can find the time, or somebody can find the time to help identify that. So it's one of those kind of checkpoints where it's a reminder to us that we have this information, and did we maximize what we know about the patient to pull in the appropriate people to work with them. You do want to have a huddle leader. It is usually the PCP, but it absolutely doesn't have to be. And I know that there are many situations where the MA really runs the huddle. That's what's key is that somebody be responsible for making sure that the huddle does occur. It's really easy to try something and then forget to do it or stop doing it in the hustle and bustle of things. It's a key role of the operation leaders and the clinical leaders to also help check in on this process, which we'll talk about here in a second, to ensure that it becomes part of the routine. This is the proactive work that doesn't need to take a long time but can feel like a big barrier at first. So part of what you're doing in the beginning is just building up the value of this process and helping people to use it efficiently. So in terms of when you do it, typically it would be at least once a day or maybe twice a day before each session, just depending on how the team decides to do things. It's generally kept really short. It can be really as short as 2 or 5 minutes, especially once the teams get really good at it, or it may take a little bit more time. In the beginning, we recommend setting aside 10 to 15 minutes for the huddle so that people can talk about those patients a little bit more and just kind of get used to what we're talking about and why, figure out what information is helpful and what isn't. So in the beginning, this does, again, take a little bit of time, but it quickly, as that team gets really efficient working with each other, they'll move more quickly. The next couple slides that we're going to talk about are around the visual management for this process. The visual management kind of helps keep eyes on the process. It's the main reason that we do it. I think that it's, again, one of those steps to supporting this implementation that really can be fun for people in your clinic, but it also gives you a little bit of accountability for knowing if it's occurring. So what is the visual management for the scrubbing and huddling? Here's one example, a really simple sheet of paper. I think this was done on like legal-sized paper. It could be done on any size paper. And somewhere where your provider teams operate, the question was kind of, this is up there for the team to be responsible for filling out. So for every day, they need to take note of how many patient visits were there, but then how many charts got scrubbed. And so in the end, you're working out the percentage of what percent of charts. Maybe it was 80% got scrubbed that day. Maybe the next day it was 100. Then under the huddle columns, or sorry, huddle lines, what you're looking at is did we huddle in the morning, the afternoon, and who came, and how successful was it? Did we have everything we needed? This could also be just a simple check. Yes, no, we huddled, we didn't. So the idea is that you really want to get to as close to 100% of scrubbing as you can, and you want to get to 100% of huddling at whatever frequency you determine to be right for your clinic. This is just a visual way of tracking that. You may use some color coding, kind of green to show that we did it, red to say we didn't do it. And then down in daily notes is a place that if things didn't happen for somebody to put why. And again, this is not to place blame at all. It's actually to help barriers become more obvious. So if you were short-staffed and that's why something didn't happen, being able to track that over time and see patterns might also help identify other areas that, where coverage might be needed or something else that is getting in the way of teams being able to communicate. If we think of this work as being core to primary care, working efficiently as a team, being able to track what keeps us from doing this is actually going to help move us forward and to solve those problems. So this doesn't need to take a lot of time. It can be all written down on a piece of paper. It can all be done by hand with sticky notes or markers. And here's an example of what it looks like. So on a different, for a different example. So these were just names of providers, and then they just check off. Did people get prepped? How many of the charts that you see in the first provider for Baker? 17 of the 18 charts were prepped. So, and then in this case, they're working to prep for the next day. So they're marking off, yes, no, did we prep for that next day or not? So these are two just examples that you can kind of use to determine what might be a quick and easy way for you at your clinic to track whether or not this process is happening and what questions people might have about it. So we're going to move on here soon to Maribel having a chance to talk. Wanted to remind you to not let the perfect be the enemy of the good. Just start, if you want, with 3 key preventive care measures your team most values and give yourself a chance to work on those, and then add others in as it feels more appropriate. Think about engaging your key leaders right from the beginning. Think about who might champion this initiative, who's going to be the clinical leader of the champion, and who's going to monitor it and ensure that it happens. What hurdles might get in your way regarding documentation, standardization, maybe change fatigue. And then you might want to consider just starting with one provider, MA, dyad, to do this and kind of work out the kinks before spreading to the other folks in your clinic. And you may find that could be the most efficient way to just have one group begin, and then as everything gets worked out and people feel more comfortable with the process, then you can spread to the rest of the clinic. So Maribel, if you are on the line, we would love to turn things over to you now to kind of tell us your experiences with scrubbing in the clinic. Maybe let us know if you want, wherever you'd like to begin, if some of the biggest challenges you've encountered, but also what about the process has been working well.
Okay. Good morning. So like you said, at the beginning, just hearing about the whole scrubbing process seems overwhelming. And for a lot of people, change is difficult, but things do get better. In the beginning, just finding, looking for where you have to look for things can, be very time consuming, and, you think about when am I going to have time to do this on top of all the tasks that I have. Sometimes you have to do it in between patients, so you have to multitask. We have time when the provider has administrative time, you take advantage of doing the scrubbing at that time as well, whether that's, at the beginning of the day, towards the end of the day. I will say that it depends on, how complex the panel is for each provider and how many hours they work. Some providers have more complex patients, so it does take more time to scrub, as where others, they might have an easier panel and it doesn't take as much time. For us, we do have a lot of diabetic patients, and we have a workflow that we go through, and we have some this diabetic form that we fill for the provider ahead of time. So that's a little bit more time consuming, but it does get easier. As far as the way we start, basically I try to scrub at least a day or two ahead of time. Before I would say that I had more time, and I would try to do up to a week in advance, but our panel size is, fairly complex, like I said, so realistically I can only do maybe a day or two ahead. And when I don't finish, then I just do it the next morning when I come in. And of course, there's people that are added on throughout the day. So you just kind of work those through in between patients. So what I look for is, we do have a dot phrase for, women, male, pediatrics, and all of those, let's see here. We look for all kinds of different things. Like you said, every person will have their dot phrase, but they are similar. So, whether we're looking for, women, we look for the PAP, the mammos, and for, colon screenings, we check for the kids for the vaccines. So one thing that is helpful for me is that when I'm reviewing a chart, we document on the problem list. So, most of the times, when the provider goes into the room, they're going to always look at the problem list. So they can click on where we document, and I like to use color codes. So usually if you look at it, it's just black. And if you actually click on the, the dot phrase that we have, if you go into it, you can put different colors on there. So I usually put red for something that's due, blue for something that's pending in the future or, isn't quite due yet. And I also do pre-visit plannings. Pre-visit plannings, I order anything, any back office labs, any immunizations that I need to order. I do them as a future order. And so that way when the patient comes in, I already know in advance that I've, ordered it. All I need to do is just release it so it doesn't take as much time as, do I really need to do this or not, or, just the time to order it. So the pre-visit planning really does help me, even though at the beginning it was, another step to do, but it saves time in the end. Let's see here. Once I'm done with my scrubbing, the next day in the morning, me and the provider do huddling. In the beginning, I will say that they gave us 15 minutes to do huddling every day in the morning, and they want us to do huddling with the whole team. And since we are team-based, in the room, you have the providers, you have the PCC, you have the TA who deals with the referrals, and the nurse. But not everyone needed to be included at the same time. So what we've done now is usually when the provider comes in, he comes to where I'm sitting at, and we'll just go over the schedule real quick. Sometimes it can take a few minutes where there's some of the patients that we've just seen the week previously, so we kind of know what's going on, or they're pretty straightforward. Maybe an ER follow-up, and he tells me that he already has the notes, or he might tell me you need to get the notes for me, so I can do that, or either the PCC. When we do our scrubbing, our huddling, with our diabetic patients, usually what happens is that I will go in, I'll do everything that I need to do, back office labs, then I hand it off to the nurse if their diabetes is out of control, and then the nurse will then hand off to the provider where he goes in to see the patient. Not everyone needs to see the nurse, so he and the nurse will talk and say what patients they're going to see, and then they'll let me know so that I can know in advance what patients the nurse needs to see. So basically the provider is the one that kind of goes off into the team and, says, tells the nurse, I want you to see this patient, or, to the PCC, can you get me these notes? But he can also tell me and I can do it. So it just kind of depends on how it works for each person. I will have to say that building trust is very important because I've been working for my provider for many years, and we're at the point where he just kind of knows that I do the scrubbing well enough that he can trust that whatever needs to be done will get done. Here at the clinic, we have floats, so I'm not always the one that's rooming the patient. If I'm on break or if I'm busy with him and in a procedure, there might be someone else rooming my patient. One thing that I found helpful for me, but not everyone does, I would say a handful of the MAs here do it, is on the appointment note, I put what the patient needs done. So when I go to the appointment and you see the scheduling time and message, there's this, when you right click, there's this thing that says message. And on the message, I will put what the patient needs. So rather than looking at the problem list and looking at the whole thing, all I do is just put on the message, maybe a patient needs a vaccine, do back office labs and whatever's needed. And so it just is kind of like a quick view of what you need to get done rather than looking at the whole thing. So that is helpful for the floats because when they're helping and the patient shows up on the arrival list, there's this little thing that looks like a paper. They click on it, and then they're like, oh, okay, this patient needs a height, they need a tetanus, and it says here that it's already in future orders, so I don't even need to worry about ordering it. And so it's very helpful for me and for whoever else is helping. So I do that. Not everybody does it. Usually I just, cut and paste, or, it just takes a few clicks to type. So it's not very time consuming. I would just say it takes seconds to do, but it really does help me.
That's fantastic, Maribel.
Yes.
Yeah, you found a lot of ways that you're thinking about the team and how you can help each other a little bit more.
Yes,
so
it does help because, when we're in the team, we're all kind of on the same page. So, they know what needs to be done for what patient, and, the doctor doesn't need to worry about it because we're already taking care of it for him.
Great. Thank you so much. I'm sure that other people might have questions for Maribel. So, Kate, I wondered if you had some questions that were coming forward.
Yeah, just a reminder to folks, if you have questions or an example or a case that you would like to share, you can write that in the GoToWebinar control panel. Type that in, and I can read it over the phone lines. One of the questions, first ones for Maribel, was, what was it like to start doing this work, and how did it affect your relationships with other people on the staff?
Well, I would say that it made the relationship better with the other group because the teams are in a office, and so they're all together, and then I'm out in the hallway with the other MAs. So we really don't, talk or even interact because, they're busy with their things, I'm busy with mine, and now we actually do have to talk. We work together. So I think it's made things better because they kind of know what I do, and then I know what they're doing, what their job is, and so we all kind of help each other rather than, well, this is your job, you need to do this. If I'm busy, I can just say, can you help me get the ER records? The provider wants them, or, whatnot. So I think it's made it better. And our team, I can say that we get along very well, and we just work well together.
So someone wrote in and just said, thanks for sharing your experiences. Where in the chart do you document patient needs, and do you have something similar to a care manager?
We document on the problem list, and you said who's the care manager?
Yeah, and do you have someone who's a care manager or something like that on the team or in the clinic?
I wonder that in that case, I wonder that might be the role of the nurse, I think, at Virginia Garcia.
Yes.
Maribel?
Or Casey, you might be able to talk about other instances you've seen.
Right. So some folks document, like Maribel's saying, in the problem list. In other cases, they're documenting into the kind of the care coordination note and then transferring some of that information into appointment notes, just like Maribel was saying. So I think I wouldn't say there's any, and those are negotiations that different clinics have generally based on where the providers in general want to find this information. So you know, I don't think there's any hard and fast way of going about it, and I actually think that it's something that will change in time as your EHR changes, as you get new upgrades. There may be the need to totally change where you put that information, unfortunately or fortunately, however you look at it. It's a changing process. So I would play around with what looks to be a good place in your chart. I know so like with regard to the care coordination note, one clinic really struggled with wanting the nurse care managers to also document information there, and they kind of had to talk through who should most appropriately use that space, and maybe the care manager needed to use a different space. If the question is around, you know, how the care manager relates to this work, I think that because I've seen that the scrub has happened at a lot of places, either the MA who's going to be prepping and ordering and kind of moving a lot of the work through, or having a more administrative panel coordinator follow a protocol and just look for this information. I think it's not necessarily a role you'd want your care manager to do. However, the care manager might benefit from this information being in the chart, because they too might then, if your process is to have them take over for the diabetic patients and ensure that all of those needs are met, they will see what information, what gaps still exist, and be able to encourage the patient to help close them. So they can really aid you, but I'm not sure that you'd want them to be the person doing the scrubbing.
Great, thanks. We've had a couple other questions come in, and just, I know we're about 3 minutes to 9. We'll stay on to answer the questions, so if you've submitted one, we'll stay on and work through the answers to your questions. But for those that may be signing off, we just want to let you know that there are some tools available in addition to this webinar on the Institute website, and there are links to those, and please do complete the post-webinar survey. It really helps us. One of the other questions that came in is, if you do pre-visit planning on a patient, for instance, you place an immunization order and then they don't show up for their appointment, what do you do with the charting that you started?
Maribel, can you speak to that one?
It remains pended, so that's where the pre-visit planning helps. It'll say, you know, what day is the patient expected to come in and what day it expires. So it will expire 24 hours from when the patient was supposed to come in, but you have the flexibility to change the date of when it expires. So I usually just put it out like a month in advance, because sometimes our patients, if they, you know, miss an appointment, they might come in 2 weeks later. So that way, the work that I did that day, you know, doesn't just go to waste. It'll be there waiting for when the patient actually comes in the next visit.
Great. And then when do you scrub charts, and how long would you say that it takes you?
For some of our patients that come in frequently, I can say that, you know, once they're up to date, then it might only be, you know, like maybe a 30-second review, or, you know, maybe up to a minute, just kind of reviewing that everything that's in there is correct. I don't always have time to update the problem list at the time of the visit, so things that might say that they're due, I don't always go in and update that date. So on the next time, I would go back in and update anything that was done on the last visit. I would say the people that take the longest would probably be the diabetics, which can sometimes take me up to 5 minutes, only because we do have a diabetic flow sheet that we go through to prepare for the providers and the nurses in advance, and, you know, the time that it takes to order any back office labs if they haven't been here in more than 6 months. But for the most part, I would say it only takes a few minutes.
Great. And then there was one other question about, do you work with one provider specifically, or just what kind of there are different staffing models. So are you working with one provider most or all of the time?
Yes, I only work with one provider unless he's not here. So I'm the main MA, but sometimes when we are behind, that's when a float will come in to help.
Great. And then just on average, do you know how many patients you see each day? And then a follow-up for Casey would be, if there was a practice with maybe a little thinner support staff, have you seen this work?
We see about 16 to 21 patients a day now. It just depends because the provider changed his role to head clinician, so his panel size has changed. But I would say as before he had his change, we were seeing approximately about 21 patients a day.
Great, thanks. And then Casey, just one last question, and then we'll conclude the webinar. Have you seen this work in models where there maybe is a little bit less staffing support of medical assistants and nurses and things like that?
Yes, what I've seen is that in that situation, it may not be the MA who is doing the scrub. What tends to work better then is to have one centralized person, either at the clinic or even across a couple clinics, who can follow the same guidelines and protocols and do the hunting around in the chart, and then document that information and basically set things up for the medical assistant and the provider. So they would be covering more teams, and you wouldn't have a one-to-one with each team, but that can work as well, and they can cover panels where the providers are seeing quite a few patients every day.
Great. And then just one more from Maribel. Out of 21 patients, how long would you say you're scrubbing in a day, though? So not per patient, but where in your day do you do these tasks?
I do them when the provider has administrative time in between patients when he's in a room, and when I have both of my rooms with patients and I really can't do much wait till the provider comes out or waiting for instructions, then that's the time that I take to scrub. Also at the end of the day I usually have about an hour, so those are the times that I take.
Great. Thank you so much to both of you for presenting the webinar today. Really great information, really specific examples, and we really appreciate you taking the time out of your day to share this information with everybody. And thanks to everyone who's joined today. Again, please do complete that post-webinar survey and let us know what you thought, and I hope everyone has a great rest of their day.
Great, thank you so much. Good luck to everybody.